Good morning, honorable members of the Pharmaceutical Society of Kenya. Welcome to this webinar. I would like also to extend a warm welcome to our guests from other cadres. My name is Daniela Munene. I'm the CEO of PSK, and I'm your host for this Pharmacy COVID-19 Dialogue webinar series. And today we have a very distinguished panel that's going to discuss various issues of pharmacy practice in this webinar. And I'm looking forward to fruitful discussions. So I would just like to introduce our moderators for this series. So as usual, our moderators are Dr. Michael Mungoma. He's a member of PSK. He's also the Dean School of Pharmacy at Mount Kenya University, and he's a member of the PSK National Executive Committee. He's also a member of the PSK COVID-19 Response Task Force. Karibu sana, Dr. Michael Mungoma.
Thank you very much.
Right, we have a second moderator who will be joining us later. This is Dr. Sylvia Opanga. She's a member of PSK and a senior lecturer at the School of Pharmacy at University of Nairobi. She's also the chair of the Education and Public Health Committee of the PSK COVID-19 Response Task Force. She'll join us later. Dr. Mungoma, kindly acknowledge her when she joins. And for now, over to you, Mike.
Thank you very much, Daniela. Good morning, everybody. Once again, we want to thank you for taking time this morning to come and participate in this webinar and share with us as the pharmacy workforce. So the Pharmaceutical Society of Kenya again is hosting this webinar. And before I continue, there are a few ground rules and announcements to make. The first is that participants are going to be muted during the entire course of the webinar. Please ask your questions through the Q&A tab that is at the bottom of your window. I would encourage all the participants to write in their questions as soon as they think about their questions and not wait until the end of the webinar. That way, even the panelists and the presenters are going to be able to look at the questions in good time to respond to them. So the questions will be addressed by panelists later in the program. For PSK members, if you haven't done so, please subscribe on the PPB portal for today's webinar so that you can earn your CPD points. For those from other cadres, we acknowledge the pharmaceutical technologists that have joined us. Kindly also subscribe on the PPB portal, but also note that we are also going to be sharing this webinar recording with your officials so that in case that has not been noted, they'll be able to do the necessary from their end. Also note that CPD points will only be awarded to paid up members. This webinar is being recorded and the audio will be made available on the PSK YouTube page. Today we are having a slightly different arrangement and we are going to have a special session moderator who I'm going to introduce right away. The special session moderator is Dr. Faith Mwangasha. She holds a Bachelor of Pharmacy degree and a Master's in Pharmacy in Internal Medicine and Critical Care. She's a clinical pharmacist at Coast General Teaching and Referral Hospital. She's a passionate believer in pharmacy beyond dispensing. She is a team leader in COVID-19 response at the Coast General Teaching and Referral Hospital. I'm going to hand over the session to Dr. Faith Mwangasha, who is going to introduce our panelists and take us through this session before she hands over at the end. Welcome, Dr. Mwangasha.
Thank you very much, Mike. I'm grateful to have this opportunity to address us concerning our presentation
Dr.
today.
Mwangasha, please move closer to the microphone. We can't hear you very well.
Oh, sorry. Hello. I hope I'm clearer now.
Yes, you are, but a little bit, I don't know whether it's closer or there's a bit of noise there, but yeah, just proceed.
Pardon that. I'm sorry for the technical mishap once again. I hope I am better. I'm better at this time round. As Mike has graciously introduced me, I'll be our special session moderator today. The presentation being a research project
Dr.
presented by.
Mwangasha, let me interrupt you a little bit. I don't know
Yes.
whether you'd probably have to move to, I don't know, maybe a different location or something. We cannot really get you. So we'll just give you 1 minute to make an adjustment.
Okay, I am sorry for the mishap once again. Yeah, I would like to introduce our panelists today. They are two doctors, our interns that we have been working with. We have Dr. Sheba Kwamboka and Dr. Jacqueline Wawera, who will be leading us through this session. The session is on the audit of prescriptions that we have in CGTRH. Their study was based on whether these prescriptions we see are according to the WHO guidelines. As we said earlier, our passion is pharmacy beyond dispensing, and there is no better way to begin this other than by first addressing the quality of prescriptions we are receiving. I would like to hand the meeting over to Dr. Jacqueline Morera, who will proceed with the presentation up to some point, and afterwards she will hand it over to Dr. Sheba Kwamboka. I would like us to do this as seamlessly as possible in the interest of time. I am sure I will improve my audio as the presentation goes on. Dr. Jackie, please.
Hi. Good morning. Can you all hear me?
Yes, Dr. Jackie, you are well heard. Proceed.
Oh, okay. So, can we start the presentation?
Yes, Jackie, proceed.
Okay, let's go to the first slide. So we'll start by looking what good prescribing is. So we all know drugs are the stronghold of medical treatment, and it is imperative that they should be used properly so that they can be okay. So it's imperative that they should be used properly. So according to Nick Barber, who was a professor of the practice of pharmacy, he stated that good prescribing is one that accomplishes the 4 objectives, that is to maximize effectiveness, to minimize risks, to minimize costs, and to respect the patient's choices. So with this, the model of good prescribing brings together the traditional balancing of risks and benefits with the need to reduce costs and the right of the patient to make choices in their treatment. Next. So there are 2 types of prescribing. So there's the rational or the appropriate prescribing. There's the irrational or inappropriate prescribing. So according to WHO, the rational use of medicines requires that patients receive medications appropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time and at the lowest cost of them and their community. So it is a process whereby you define the patient's problem, you specify the therapeutic objectives, you verify whether your personal medication and choice is suitable for the patient, you start the treatment, you give guidelines and warnings, and lastly, you monitor the treatment. Irrational or inappropriate prescribing is described as medically inappropriateness and economically ineffective use of pharmaceuticals. It is a global health problem, with WHO estimating that more than half of all medicines are prescribed, dispensed, or sold inappropriately, and half of the patients do not take them as indicated. So common irrational uses of drugs include overuse or underuse of medication, high cost of drugs, which is brought about by extravagant prescribing, more usage of injections and antibiotics, polypharmacy, violation of standard treatment guidelines or non-essential drug list, use of brand names instead of generic names. This leads to the ineffective treatment, development of resistance, as we all see in antibiotic resistance, which is a major challenge, adverse effects, and economic burden on patients. Next slide. Next slide, please. Okay, so what is a prescription? It is a medical legal document that is written, which can be handwritten or electronically written by an authorized healthcare provider, which directs the pharmacist to prepare or dispense the medications to a patient for the diagnosis, prevention, or treatment of a disease. It should be written legibly and accurately to avoid errors, since the errors promote the irrational use of drugs and decrease the patient compliance. Irrational prescriptions unnecessarily increase the cost and duration of the treatment and lead to the emergence of drug interactions, drug resistance, and advanced drug reactions. Next. So ideally, a prescription should include the date, the patient information, the treatment plan, and the prescriber's information. Next slide, please. Next slide. Okay, so with our study, which was the assessment of drug use pattern using the WHO prescribing indicators at the outpatient pharmacy in the at Coast General Teaching and Referral Hospital, this was basically performing a prescription audit. So what is a prescription audit? It is basically evaluating the data of a prescription to see if it meets the specified standards. So prescription audit is among the 12 core interventions of promoting rational drug use. It is a part of the holistic clinical audit and is a quality improvement process that seeks to improve patient care. It is an educational activity that should be done regularly so that it can be able to improve the prescription quality and enable the patient to receive high standard and best quality care. Next slide, please. So to assess the quality of drug treatment, WHO came up with indicators which are used as a standard to measure the performance of prescribing in any health facility. So the WHO, so the indicators that were developed by the WHO were they measured the performance in 3 related areas. That is the prescribing practices, the patient care, and the facility specific factors. So for us, for our study, we focused on the prescribing practices indicators, which when we go to the next slide, so when we go, when we go to the next slide, as you can see the outline, there's the prescribing indicators, the patient care indicators, and the healthcare, there's the healthcare facility indicators. So for us, we focused on the prescribing indicators, which include the average number of drugs per encounter, the percentage of drugs prescribed by the generic name, there's the percentage of encounters with an antibiotic prescribed, there's the percentage of encounter with an injection prescribed, and the percentage of drugs prescribed from the essential drug list of the hospital, which the Coast General Hospital has a formulary which General Hospital has a formulary. So with that, I will let my next colleague to take up the next part of the study.
Thank you. Next slide, please. Next slide. So for the methodology, we collected all prescriptions as from October 2019, 1st October to December 31st. And we randomly sampled 1,500 prescriptions from all those. According to the WHO indicators, there was a slight modification which was made so that they could be used to easily provide accurate data. So for our study, we concentrated on the prescribing indicators, as Jackie has said. And after analyzing the data, we came up with these results. Next slide. So out of the 1,500 prescriptions, we had a total of 3,586 drugs, different drugs encountered. Then out of the 1,500 encounters, 556 of the prescriptions had antibiotics prescribed. Then 2,090 prescriptions, 2,090 drugs had been prescribed by the generic name, while 3,580 drugs were from the essential drug list. So for our main indicators, we'll start with the number of drugs per encounter. As you see from the table, the average number of drugs per encounter was 2.39, but according to the WHO standard, it should be between 1.6 to 1.8. So our value was definitely higher than the standard of WHO. This could be maybe due to financial incentives to prescribers to prescribe more, or maybe lack of therapeutic training to prescribers. Also, WHO prescribing indicators do not take into account specialty outpatient clinics where the drug use pattern is more complex. And by specialty outpatient clinics, I mean the clinics whose patients are being treated for hypertension and diabetes. As we know, these patients use a lot of drugs. Yeah. So while Kenya had a value of 2.39, Nigeria was at 3.8, while Sudan was at 1.4. So Sudan were within the WHO standard. This may be due to a constraint in the availability of drugs. For the next indicator, which is the percentage of encounter with antibiotics, our value was 37.06%. According to WHO, as you all can see, it should be between 20 to 26.8. So clearly our value is higher. So antibiotic prescribing first should be regulated, since overuse could facilitate emergence of resistance. So our value could be higher, maybe due to cultural beliefs about antibiotics, and also patients' expectation to receive antibiotics. Some patients will come to you, you treat them, then when you don't give them an antibiotic, they're like, mbona haujanipea antibiotic, nitapona kweli? I know most of you can relate to this. On to our next indicator, which is the percentage of drugs prescribed by generic name. We had a value of 58.3% against the WHO standard, which is 100%, meaning that according to WHO, all drugs should be prescribed by generic name. But the reason why our percentage is this low is because of maybe financial incentives from pharmaceutical companies to prescribe their drugs, especially using their brand name. This should be discouraged as it may lead to confusion and dispensing of the wrong drug to the patient. Comparing with other developing countries, Nigeria was at 58%, Sudan was at 63%, but the values were encouraging in countries like Tanzania, which was at 82%, and Zimbabwe, which was at 94%. Moving on to the percentage of drugs prescribed from the essential drug list, our value was 99.85% against the 100% recommended by WHO. So this was highly commendable. And prescribing from the essential drug list was generally not found to be a problem in this study. Next slide. So from this study, we can see that the prescribing practices for antibiotics, use of generic names, and number of drugs prescribed by encounter shows a deviation from the standard recommended by WHO. All this lead to an increase in the cost and potential harm to the patient. So commonly overused and costly forms of drug therapy need to be closely regulated. Yeah, next slide. Thank you.
Hello, everyone. Thank you so much for having given us your time and for having heard us through. Maybe just to summarize the salient features of our presentation. From our study, it is clear that there could be an overuse of drug. There's an overuse of drug prescriptions. That is to say, drug commodities are being prescribed at a rate that is not compatible with the one for WHO. So that is one point we have noted. And then there could also be misuse or overuse of antibiotics. But it's commendable to know that our prescription is done from our essential drug list. And we can actually acknowledge the effort of our fellow pharmacists who have gone ahead to prepare a comprehensive hospital formulary that is actually being used and it is in force. And of course, the concern of the use of the brand names in prescriptions has also been raised there. And this could, of course, be attributed to the economic implications of the person who's sponsoring such and such a drug. Those are the salient features of our study, and maybe to also give you a cue on how you're going to enter into the Q&A question that we are eagerly waiting for. But for now, I'd like to pass the meeting over to Dr. Mike Mungoma, who is going to guide further regarding the Q&A. Dr. Mike, please.
Thank you very much for the presentations. Again, thank you very much for Dr. Sheba and Dr. Awira for turning up for this webinar. I think, first of all, I must say that it's important to mentor young pharmacists. And it's a very good thing that you have good mentors there at Coast General Teaching and Referral Hospital that can guide you through some of these exercises, and that you can actually come and share some of what you're doing there. I think for me, what I would want to maybe encourage the two presenters is that we also need a bit of detail in terms of giving us direction on rational use of medicines. Yeah, we have seen from your findings there that we do not meet some of the WHO standards or the reference sort of ranges there in terms of percentages. My first question would be to the two presenters. Following the results you've gotten there for the antibiotics, especially because even today, is when they're launching the national, I think the guidelines on antimicrobial stewardship. And I was there in that presentation as well. And I think something struck me. The thing that struck me most is the ability of patients, the ability of clients to influence prescribing. The ability of clients to influence prescribing, as well as the ability of clients not just to influence prescribing, but to influence dispensing, as well as the sale of antibiotics, which is a major concern because of resistance. So for the two, what ideas, what practical ideas, not textbook ideas, would you propose to prevent the irrational use of antibiotics?
Dr. Jackie, you could take that question, and then Dr. Sheba will also give her opinion, please.
Oh, should I go and answer the question? Or
Yes.
Please.
Oh, okay. So, in preventing the misuse of antibiotics, in my opinion, I would, since most patients, they normally Google up their symptoms, and with Google, they give the certain types of antibiotics that should be used on such on such ailments. For me, what I would do, I would first sit down with the patient, consult the patient, try and come up with, try and understand where the patient is coming from. With that, then we can move to with that, I can be able to move to give advice to the patient on why they should use the antibiotic or why they shouldn't use the antibiotic. Yeah.
Dr. Sheba, could
So who was talking there? Was it Dr. Owira or Dr. Sheba?
It was Dr. Wawir.
Okay. So Dr. Sheba?
In addition to that, according to me, my answer will be on the facility, or rather the hospital. Most of these patients are treated even without lab investigations. So we should equip our lab fully to make sure that certain tests are carried out so that we can minimize empirical treatment with antibiotics. And also the answer that Jackie gave, sit down with the client and explain to them that they don't have to use the antibiotics, maybe for that particular condition, and some other drugs will do. Thank you.
Dr. Mike, may I add something on the responses that have just been given by our panelists, by our presenters?
Yes.
That indeed it is a challenge to see that we are actually over-prescribing antibiotics in the face of looming resistance. But I'd also like to contribute and say that maybe the prescribers just take a shortcut, you know, like they just prescribe antibiotics assuming like it could just cover whatever bug that is affecting a patient, you know, instead of doing the right thing, like doing the lab investigation, the tests, the history. They just feel they can just have a one-size-fits-it-all kind of antibiotic, like let's say amoxicillin capsules, or maybe fluoxetine for something like that looks a little chronic, a little bone issue. So I think we have to bring everyone else on board and tell them that it's okay to go that extra mile, other than just do a convenient coverage of, you know, to just cover whatever there is, even if maybe there's no need for such an antibiotic.
Okay. Thank you for that addition. There's something, there's a question, sort of a comment from Roslyn Moin, who wants the panelists to highlight some challenges faced during while carrying out this research? What was some of the challenges faced while carrying out this research?
I guess I can answer that. One of the biggest challenges was that the prescriptions did not identify the cadre of the prescriber, because some patients may see a clinical officer, others may see a medical officer, while others may see a consultant. So the prescriptions did not specify the cadre, because some antibiotics might have been prescribed legitly. That's why just a minute. So another limitation was that the WHO prescribing indicators are supposed to record exactly what is prescribed to patients, but not why. So in order to explain why, other techniques are needed. And most of you can attest to this, that the prescriptions usually do not have a diagnosis. You just get a prescription, it has drugs, and you have to dispense the drugs, but you do not know why this particular patient has been given these drugs. Yes, those are some of the challenges we found.
Okay. Samuel Gitau says, the conclusion of these studies is dire, so there's overuse of drugs. Have you instituted measures to combat or reduce this? He says that he can almost predict these findings can be replicated in all hospitals and pharmacies. Is a national policy needed to comprehensively deal with this?
I think I would like to handle that question there.
Mm-hmm.
Well, let me start by saying that this is step one. We have identified there's a problem. So maybe our next step here is to take a few of those prescriptions in the sample, the ones that bear the salient feature of over prescription, where a drug is being prescribed where it is not needed. And then we hope to bring on board the prescribers, like to justify why we feel such and such a drug ought not to have been prescribed here. And then maybe we're hoping to do a few CME sessions, like to sensitize them that we have noticed a problem. And it's in the interest of ourselves and our clients to tackle this problem. And then from there, we hope to be doing step two, where we'll be telling you that this is what we did and the results has brought us this far. So in short, I'm saying this is step one. We hope to do step two. Mike?
Okay. So we're saying that we are taking steps, but this is just an initial step based on information that we have gathered. What I want to ask myself is, how do you encourage generic name prescribing when there is very aggressive marketing of brands?
Oh, indeed, that's a product for the sake of their company, their sake of their income. But I think we have to strike a balance, like between the marketing effort and also just doing a genuine CME. Okay, let's say after the marketing CME pharmacy department, a neutral CME, just maybe let's talk, for example, anticoagulants. When we do our CME, it's mostly centered on the generic name other than the proprietor name. So when we do that, I think we are hoping that our prescribers will have a take-home message. Yeah, that what we are interested in is the molecule, not so much the brand name. But of course, I must reiterate that it still remains a challenge because of the incentives that are being given by the marketers, but of the prescribers to balance, to strike.
Hello, Dr. Are you still there?
Yeah, yes, Dr. I'm here.
Oh, okay.
I hope,
You were
yes.
breaking. You're breaking, but it's okay. What I hear is that it is not easy. The marketers are also very big players, but so could we say that marketing has contributed towards the irrational or misuse of medicines?
Certainly, I can say that. And I believe that is the opinion of most people, because marketing is about targets. And the marketer does not just come to you without hoping to get anything from you. He's coming there to get something from you. And sometimes our prescribers have been compelled to over-prescribe a product, or to biasly prescribe a particular product, uh, just so that they can please some person who is also meeting a certain target. So maybe the best way to address such a problem would be to regulate the marketing operations versus the professional operations. That's what I feel.
Yeah, maybe just to challenge you before I get into another question. Marketing is done by pharmacists as well as pharmaceutical technologists. And sometimes we end up now blaming ourselves. And that is why I asked, where is the balance? How do we ensure that marketing supports rational prescribing and rational use of medicines?
Wow, indeed, that's a challenging question, because here it's like I'm walking a live wire here.
So instead of what does Dr. Wawira and Dr. Sheba think? You know, it doesn't have to be, because here the platform is all about sharing, and when we share, we open our minds, and we're actually able to look for solutions to problems that face us as a workforce or as a sector. So what does Dr. Wawira, what do you think about what I've just said there? Because we are employed as marketers, we are marketing managers, we want our products to move, but at the same time, we are saying that some of these medicines are just being prescribed or dispensed without sort of due diligence. What are your thoughts?
Okay, my thoughts are how I practice pharmacy is I always think about the end user, and the end user is the client. So with that in mind, I can prescribe the correct drug, giving them the right dosage, and also bearing in mind how it's going to set them aside when in terms of the monetary bit. So for me, I just practice pharmacy with the end user in mind.
Samuel Gitao is still asking. Or he's actually commenting. Well, I do advise patients against self-prescribing antibiotics irrationally. So, do you in your hospital advise patients against self-prescribing antibiotics? Sheba?
My answer to that will be definitely yes. And this should not only occur in the hospitals alone, but also in our pharmacies. The patients should be made aware that self-prescribing is not good, because this might lead to resistance. You can tell the patient that the more you use this drug, a time will come when it will no longer work in your body when you actually really need it. Yes, that will be my answer to that.
Maybe Dr. Mwangasha could answer this. There's an anonymous person. What action has your MTC taken from the findings of this study? I'm assuming
Yeah,
MTC is
well,
Medicines and Therapeutics Committee.
yeah, indeed it is. Like I said earlier, this is only step one where we have identified the problem. So we are still going to do step two where we will see how best to tackle the problem. So
What thoughts
yeah.
do you have so far?
From the study, the salient points that have come up is the overprescribing of the drug products and then of the antibiotics. So like I said, we want to get real-time prescriptions with maybe the real prescribers and just try to have a CME, let's say with our clinical officers, and then the next one with our medical officers, and just try to bring them on board by giving them specific examples of what we mean when we say someone is overprescribing, or the danger of prescribing an antibiotic that is not needed. You know, I feel when you give people statistics, when you give people numbers, you bring them on board in a better way than just giving them a blanket message. So step two would be to address specific issues with the hope of changing attitudes and habits.
Okay. So I think what I'm also hearing is that it's not really a straightforward sort of response. We need participation by all players, including the prescribers as well as the handlers or people in supply chain, as well as the marketers, to ensure that these drugs are just not being written on prescriptions, and are also not just being dispensed because they are available. Maybe I would like to take you to the presentation, and there was a slide there on prescription audit. I don't know whether we can, I don't know, is it Peter who is controlling this, or who is controlling the presentation?
Yes, Mike.
Yeah, so if we could just go to the slide with the prescription audit.
Okay, I'm getting back to it. There you go.
Yeah, so maybe, I think it's the next slide.
The one before or after the prescription?
The one after,
audit?
the one after.
This is what comes after.
So the one after? Oh, yeah, that one. No, I think it was the one before, sorry. Just let's go back to that prescription audit, yeah? Because my question is actually to Wawira and Sheba. Could you briefly describe how you do this practically in your setting? How do you audit prescriptions? Just in sort of your own experience, or in real life, or day-to-day practice. How, or what have you seen? You've observed Dr. Mwangasha doing it, but I just want the two of you to describe what exactly happened.
So if I may answer this.
Yes.
At the hospital, we have a hard copy of a form which contains the WHO prescribing indicators. So you take a prescription, then you tick it against the hard copy. So the hard copy contains these indicators. For example, it will have a section with the patient details where there's a name, the clinic the patient is visiting, the age. So if the prescription has all those things, there's a code you indicate for yes and a code for no. So that's how we basically do the audit.
If there's a no, what happens?
So the results that we get from that is what we recommend to the hospital, and we try to improve on, like Dr. Faith said, this is just the first step. So we are now on to taking the next step.
Okay.
Yeah.
So that was Dr. Awira, yes?
That's
No, it was Dr. Sheba.
Dr. Sheba. So Dr. Awira here, there's a question from Daniel Njuguna.
yes.
Do you think frequent prescription audit will help in combating irrational drug use?
My answer would be yes. Because with our study, we performed the prescription audit. So you take the prescription, you evaluate what information is in that prescription. So with that, you can see what are the positive outcomes and what are the negative outcomes with that. So with the negative, you try to improve the negative outcomes and try to maintain the positive outcomes of performing a prescription audit. So I believe, yes, it should be, if not annually, if the hospital or any other health facility can do it regularly, then that would be fine. But it is recommended that you do it annually, so that also with that, the hospital or the committee can come up with certain objectives of the next financial year. Yeah.
Dr. Faith, can you maybe make some additional comments on the frequency of prescription audits?
Indeed, I would like to agree with Dr. Wawera that this ought to be a process that is best done annually. So that but the most challenging, like after we find where the problem is, we ought to address this problem so that in the next financial year we would be reporting on what was done after audit 1. That's what I'd like to add.
Okay.
Dr. Mike?
Yes. Thank you for that. So Vincent Nyandoro says, marketing gives us the drug options available in the market and not what we give our patients. We should maintain professionalism at all times. We should not succumb to marketing pressure and promote irrational drug use. How, as an institution, do you manage marketing pressure?
Wow. I will answer this question, and then I will also invite the input of Dr. Jacqueline and Dr. Sheba, like to see how true my answer was as a neutral. Them they could be observing as neutral observers, you know, to check me in case I'm exaggerating this point. Indeed, I would like to say that ideally, that is the ideal statement, that a marketer is only supposed to tell you what he has, and you are under no obligation to pick what has been marketed to you. That is your right as the consumer. You have the right to be informed about what the marketer has, but you are ideally under no pressure howsoever to buy. But to be practical and to be as honest as I want to be, we are all under the pressure of marketing. Yes, we will try to justify it as rationally as we can, but as human beings and as prescribers, they are all under the pressure of marketing. So I would like to call on all of us as the professionals in this profession to be honest with ourselves and see how we best handle this. As a hospital, I can say we really have restricted the movement of medical representatives in the institution. They no longer come directly to the prescribers. They have to pass through the administration. But in the long run, even if the hospital filters the coming in of the marketers, in the long run, it depends on individual prescribers to decide what to prescribe and why. Maybe let me invite Dr. Jackie to contribute a little.
Dr. Faith, I believe you've said it all.
Come on, Jackie.
Okay. Jackie, we are not going to put you on the spot. So Anne Karanja makes a comment on marketing. So pharmacists should step up and diligently collect information on the patient's experience on every new brand. This will inform us which brands to stock in our hospitals, pharmacies, or KEMSA. In this case, then the brand given will not matter, only maybe the price. Huh? Dr. Farida asks, in the prescription audit, you wrote about regular training for writing improved prescription quality. How have you achieved this with the doctors, both junior and consultants? I think these are very important questions. How is your interaction with the medical doctors, both junior as well as consultants?
Wow. Honestly speaking, as we are going on with this presentation, it's like we are getting a new to-do list for the new year, you know? With every contribution, there's a new task for us. And it's inspiring, why lie? You know, we're feeling like we are stakeholders in this thing who have been sleeping on the job. Okay, now to answer the question, let me just say I am challenged. Indeed, we have identified the problem. Indeed, we have seen it. Now, Dr. Farida, the owner of the question, we promise that in the next few months, you will see CMEs to all the junior doctors and the consultants. As I have said earlier, this is step one. Now for step two is to get everybody else on board. And you have noted there's a, I think from the spirit of the question I read, you're foreseeing a challenge. Like, how do we get these people to speak our language? So I'm saying again, we are going to use these same statistics based on this study and many more to bring them on board as diplomatically as possible, so that we don't look like we are loading it over someone. We are just speaking in the best interest of our clients. So yeah, watch this space. You'll be seeing more of these people. Thank you.
Okay. Emanjue says, hello, who is responsible for ensuring that there is a change of outcome in subsequent years? I feel an audit isn't enough if it is just carried out as a task. How do we ensure the prescribers get the information results of the audit, and who checks on the implementation of the recommended actions?
Dr. Mike, I sure wish Dr. Makori was here to address that particular question. Let me give this to Dr. Sheba to give us her input of what she would like to be done, because that is indeed a crux of the matter question. Dr. Sheba, please.
Yes, before she talks, remember that this is a very good discussion, because we are challenging ourselves. Huh? We don't have all the answers, but we can suggest certain solutions. Again, this is dependent on facility to facility, and based on experience, on the various experiences people have, and also the structures, because there are certain facilities where the structures might be quite rigid in terms of who communicates to who. But when it comes to medicines, I think, the pharmacist really needs to take a lead in terms of guiding, especially if we are there. So don't feel over challenged or, let's just share our experiences as is. And I think that will build knowledge as well as experience. So, Sheba.
Yes.
Who is responsible for ensuring that there is change of outcomes in subsequent years?
So according to me, everyone who's attending this webinar is responsible for whatever place they work in, because we cannot just leave all this work, maybe let's say for the chief pharmacist, or everyone has to be responsible. If in your facility, since we have talked about these prescription audits and what is required, if in your facility you see that there's something not right, maybe talk to the rest of the pharmacists or pharmaceutical technologists, or talk to your leader and inform him about what you guys need to do and what you don't need to do. And on the question about how do we ensure the prescribers get the information, platforms like this, webinars, seminars, conferences, we can have CMEs to inform all these people about all this, so that when each and every healthcare worker is performing their work, they know what they are doing. They're just not working for the sake of working, but they'll know what they are doing. And on the last question on who checks on implementation of the recommended actions, I guess that I don't know, maybe Dr. Faith can help me in answering this.
Wow, Dr. Sheba. Well, you're asking for the net results of this whole process. Well, as I say, we are still on the baby steps of the process, but
Yes.
I'd like to remember the point that Dr. Sheba has just put through. But indeed, we are all stewards of this product. So maybe we should come up with a guideline of assessing our own input. You see, like for whatever process you do, you normally do the SWOT analysis. You see where the weaknesses are, and then you address the particular weaknesses, and then you have a measurable outcome. So I'm looking into a way of doing maybe even a 3-monthly kind of, not 3 monthly, quarterly, yeah, that is 3 monthly, quarterly kind of assessment of this process.
Okay, I think we're getting some very useful information from this discussion. What I want to point out that is coming out is stewardship. Stewardship is very important. Like I said today, they just launched some guidelines for the antimicrobial stewardship. And we need stewardship for medicines in hospitals or facilities where medicines are dispensed. Dr. Sheba talked about discussing with your leader as well as other cadres. So that already gives us a sense that we need a structure. We need a structure that is actually able to monitor the use of medicines, the availability of medicines, who is handling these medicines, so that at the end of the year or whatever period that you're auditing, you can actually have results that can be tagged not only to WHO standards, but to standards that have been set up in that hospital or that facility. The other thing is, Musundi Oganyo is asking, how did you come up with a sample size of 1,500 prescriptions? Is it representative considering the hospital workload? That is a very statistical question. Maybe any one of you can answer.
Dr. Wawera, I'd like to pass that question to you. Like in the methodology, did you include how you calculated the sample size, maybe what statistical formula, or is it just an arbitrary kind of choice?
It was an arbitrary kind of choice, because with most studies, you'll see most of the studies carried out, the prescriptions were around 600. So we were just working with that.
Okay.
Yeah.
Yeah. So that, yeah, I mean, you could even, I don't know how you did it, but it could have been the total number of prescriptions that were available during the period of the study. Yeah. Dr. Farida Chakera is saying, in the government sector, there is KEMSA that can help regulate the brands. How do you advise the private sector to get on the same page, as there can be a lot of pressure from outsiders? We are told by the authorities that it is okay for as many companies to bring in their medications. As you think about responding to that, I'm informed that Dr. Yaile is present here and he had raised his hand. So after this, after responding to this, I'll give Dr. Yaile a chance to say something. So could we respond to how do we advise the private sector to get on the same page, as there can be a lot of pressure from outsiders, and that, they are told that as many companies as possible can bring in medications.
Okay, let me try to respond to that question. And I would like to say that the WHO and from the essential drug list of the WHO and maybe from regional studies, like maybe somebody could even borrow our hospital formulary to just look at the kind of drugs that we recommend for the population. Because I would like to say, as a public hospital, as a big regional public hospital, we represent quite a big knowledge of the health needs of the region. So I would like to advise our colleagues in the private sector to just base their choices on the WHO essential drug list and also on the regional hospital formularies. In fact, they can have a chance to compare, like maybe ours and another major hospital, and then they can come up with their own that is based on their particular facility. You know, as somebody has pointed out, the marketers will always bring in what they have. But in the long run, the buck stops on us, the consumers. We are the ones to decide what we need and what we do not need. And nobody can pressure you if you have a ground you're standing on. So basically what I'm saying is that they need to have their own formulary, their own guideline of what they need based on the regional needs.
Thank you for that.
Dr.
I think,
Mike?
yeah, that's a very good response. We need to evaluate our own institutions and see what is there, what guidelines are there, what sort of, again, structures we have. But again, it is important that the pharmacy plays the role that it needs to play in the hospital or whatever facility is bringing in those clients or patients. Dr. Paddy Agoro is saying, thank you for the invite. This is a very pertinent issue. His question is, do we verify the authenticity of all medical representatives before they serve us? Dr. Wawira.
Yes.
Do you verify the authenticity of medical representatives? Have you interacted with these medical representatives?
As of now, I can say no.
You haven't interacted with them. Dr. Jacqueline?
Yes.
Dr. Jacqueline, have you interacted with them?
As of the moment, no, I haven't interacted with the medical representatives. So
Okay.
I don't have an answer for this.
Dr. Faith, you are the person to give us an answer on verification of authenticity of these medical representatives. How do you go about it?
Honestly speaking, if it's about a verification of authenticity, other than that someone is wearing a name tag and that they politely introduce themselves, I think I'd be lying if I'd say I have actually verified the authenticity of somebody. You know, just somebody doing that social greeting and presenting themselves, that's not enough. Let's say we need to do more.
I think this is a very important question. From the regulator, we need to know who is coming in with what in our institutions, yeah? Because counterfeit products, people just using opportunities to bring in products that have not been registered is something that exploits loopholes. So facilities really need to have a way of managing these medreps, in the sense that I think I've visited certain hospitals where they even decide which days and which hours they can actually come in talk to some of these, to market their products. You know, that way, if they are regulated, it means that they can come prior to the day they're going to meet people. I know this is a challenge, especially in public facilities, because there are so many layers of administrators. So sometimes people can just go through different administrators and end up talking to prescribers. But I think it's so important that being in a position of ensuring that there's drug safety and being in a position of ensuring that medicines that are available to patients are actually what they are and not just purporting to be something. We have a comment there from Emma Njue. This is a great discussion, awakening us to take up our role as pharmacists. So I said earlier that I think Dr. Aile's hand was up. Is he available to make a comment? Dr. Daniela?
Yes,
okay.
Mike.
Yes.
You want me to allow Tony to talk?
If you can allow Dr. Aile, and you could also allow Dr. Paddy Agoro to make a comment.
Okay.
So yeah, so just so we'll have with Dr. Aile, and then we'll have Dr. Paddy Agoro.
Okay, excellent. Dr. Aile, you're allowed to speak. You just need to unmute yourself. And Dr. Paddy Agoro, be on standby to speak after Dr. Aile. There's also Dr. Apinde Sharon with a hand up. I don't know if they had put up their hand at another time.
I've unmuted myself.
Okay, good.
I can go on. I can comment.
Yes, but please come close to the mic.
Okay. Once again, thank you for having this. This is really, really important. Huh? On the medical representatives of the DCG, just the way we are registered as pharmacists with Pharmacy and Poisons Board, we also register medical representatives. Pharmacy and Poisons Board also registers medical representatives. So they have a card, they have a number, they have the way we would have a registration number, they also have their registration number. So it's important that, one, I know with county, maybe the pharmacists are not usually at the front line of procurement. But if we can always insist in our meetings that we are there, so that we can give such opinions that tell them that these facts that these people are registered. Then also to ensure that registered products are in your shelves. You can always visit our website and verify. There's a slot where you can verify that a product is registered in the market. So that, because there's a big loophole. If we are not at the forefront of procuring these drugs, there's a possibility of drugs getting into our shelves that are not registered. Hello?
Yes, Dr. we can hear you.
Yeah. So registration, a MedRep comes with a new product, he should show you the registration certificate or retention certificate of that product. They should be having, because it's just from the website, they should be having. So apart from giving you all those details of the product, they should also have the registration or retention certificate of the product. I think
Dr. we are losing you.
Hello?
Yes, go on.
I think that's all I can say for now. Maybe
yes.
Yeah. I can be unmuted.
Okay. Thank you very much, Dr. Paddy, for that insight and reminding us that we can always verify product registration from the PPB website, and that it is also very important to demand for these registration certificates from medical representatives, because, you know, with a porous market, anything can come in. And for us, I think we have a duty. We have a duty to our patients. We have a duty to patient care and safety. So even as much as sometimes we want to look nice, or we want to look, we might be quite aware of how hospitable we are to medical representatives. I think at the back of our heads, what is important is to ensure that we have safe medicines on our shelves, and that we're interacting with the right people and not the wrong people, so that we ensure that the sector remains intact. Is Dr. Aile available to say something now?
Dr. Mungoma, it may be that he had raised a while back, and maybe
okay.
Revised. Yeah.
Okay. So yeah. So again, yes.
Sorry, there is a Dr. Nyambura Wanjiru Korir.
Okay.
Also asking to speak.
Yes.
Okay.
Go ahead, Dr. Nyambura.
Good afternoon. Good afternoon. Hello?
Yes, hello, we can hear you.
You can
Good
hear me?
afternoon. Yes, I can.
Great. Great. My name is Dr. Wanjiru Korir. I'm a clinical pharmacist at Coast General. There are some of the questions you asked about the conduct of these prescription audits that I feel a bit more background would have helped. The idea to do this clinical audit started in September last year, when we were preparing for our safe care accreditation. Initially, we had been accredited at level 1, and the safe care guys were coming in to now do another evaluation and accreditation. And part of the areas of medication management that they were going to be looking at is a prescription. And that is how we decided, let's do this audit and see how we have been doing. About the number of prescriptions that were decided to be used for the sample for this study, it was the number of the prescriptions that were available at that time. Part of the challenges we had when we were starting off to do this, first with the gathering of the information, gathering of the data, putting it up in Excel sheets, was a really big challenge, because as the presenters mentioned, at times it's very difficult to determine whether the prescription was written by which cadre of prescriber. You would find that some prescribers would request lower cadre prescribers to write for them, or vice versa. The issue of using brand names or generic, the internationally nomenclature, was always a big study, as I mentioned, because of the influence from elsewhere, and the classification of the various WHO, what are they called? The various categories of the WHO recommendations for prescription audits were also a challenge at the very beginning. And that is why the checklist was made, so that it can make the work easier. So initially we had boxes and boxes and boxes of prescriptions to go through, and we really worked very hard with the interns we had at that point: 1, to sort them out; 2, to fill in those forms for the prescription audit; and 3, to convert all that information onto a spreadsheet that can then be processed to come up with the summaries that they have provided. The question about what is the way forward on this and who will decide whether we are meeting the targets we need to meet is still the same background. Because it was a quality improvement tool, we are still gonna use it as first, that was to form our baseline, just tell us where we are. And then, as Dr. Faith has commented, there are various other steps that we need to take. And we also need to do our M&D quarterly, just to check, are we proceeding well, or are we backtracking? Are we making gains on this journey? And it's very interesting that this presentation is being made on a day when the AMR guidelines have been launched. So yes, our work is cut out. Yes, the onus is on all of us as professionals to make sure that it's not only for antibiotics, it's for everything else, that we need to own our products and own the processes through which patients get to access these products. And it cuts through everything, including pharmacovigilance. It's a whole continuum of quality assurance in pharmacy practice that brought about the thought to do this prescription audit. It's a good baseline for us, and we are happy to share it with you. Over.
Thank you so much, Dr. Korir. I think you've given us, you've actually raised a few issues there that we need to follow up on. I think we'll be looking for you to do a presentation on pharmacy best practice. There's so many things you've touched on there that need a bit of expounding and a bit of sharing, and even just taking note that today we are launching the AMR guidelines, which essentially means that we need to take up stewardship roles when it comes to antibiotics as well as other medicines. Dr. Apinde. Oh, yes, you want to say something again? Go on.
Yes. I'd like to mention also that after the evaluation for safe care was done, I think Coast General was the first public facility to do the safe care accreditation that has been done in 6 other countries, and the pharmacy department was the best improved. We moved from an initial evaluation score of 30 up to 75, as in there is so much work for us to do, and we need to continue doing it so that we can keep consolidating the gains we've made and even go higher. It was all from teamwork, and this is one of those things that helped that process. So yes, we are available to continue the discussion and even take the discussion to higher levels. So you can always call on us.
That's very good. I think Coast General is doing quite a good job. We've had previous presenters again from the same facility, and they have been wonderful, including Dr. Faith. Yeah, and also just to again appreciate the fact that you have been able to mentor these interns to this point, because it's a very good thing if we have interns getting to a point where they can do a bit of work in the hospital and share with us, share with us in this platform. Dr. Apinde, hand is up. Dr. Daniela, maybe you can facilitate Dr. Apinde to speak.
Okay. Dr. Apinde, you can just unmute yourself and speak. And Dr. Yaila, if you can hear us now, you can, after Dr. Apinde speaks, you can unmute yourself. Okay, maybe it was just an inadvertent raised hand. Over to you, Mike.
Okay, and is Dr. Yaila available or not? No. Okay, so yeah, so I'm just looking at the time there, and we probably need to wrap this up. Remember again that this is an initiative of the Pharmaceutical Society of Kenya, COVID-19 response, and we are having this series of webinars so that we can share on this platform and invite other people from other cadres just to share with us their experiences during this COVID-19 response, because it is important for us to remember that we are there and know what each one of us is doing wherever they are. I want to appreciate the special moderator today, Dr. Faith Wangasha, for bringing in the interns. We expected 3, but we had 2 who did a very good job doing the presentations, Dr. Sheba and Dr. Wawira. Those are very good insights. And I also want at this point to appreciate Dr. Daniela and Dr. Peter Odhiambo for making this happen. the presentation of slides have been seamless and they've been consistently good. And again, to appreciate everybody who took some time out to join us in this webinar, including the pharmaceutical technologists and other cadres that might be here, nurses or whoever they are. I want to pass on the mic now back to Dr. Daniela to close this session. Dr. Daniela.
Thank you, Dr. Mungoma, for the excellent moderation and over this very important topic that's very timely, because as Dr. Wanjiru said, today is the day that Ministry of Health has launched two very key documents for us as pharmacists. That's the National Antimicrobial Stewardship Guidelines, as well as the National Essential Medicines List. And key to note in the EML is at this time, against each antibiotic that's in the EML, they have indicated the aware category. If you're aware is about the antibiotics that should be easily accessible and used as first line. And the WA is for the ones on the watch list that you use as second line. And the RE is about the reserve antibiotics that should never be used unless, I think I need to mute somebody, that should never be used unless, maybe they're drug resistant organisms. So I think that's a very good tool that we should put to immediate use in our workstations. And we thank the MOH for, and our pharmacists at the ministry who contributed to this, for creating this EML that flags, that acts as a tool for stewardship. We shall email all the attendees those two documents after this webinar. Remember, participants, you can also catch this webinar on our Pharmaceutical Society of Kenya YouTube page. It will be uploaded there by Friday, and you can also catch up with the previous webinars, COVID-19 webinars that we've held. Next week, we're a team of Africa, and they'll be talking about pharmacy services during COVID-19, and they will drill down to immunization services that are pharmacist-led. So that's something worth looking forward to. The following week, we shall have Dr. Evelyn Wesangula, who will talk about IPC. That's on 5th August. IPC in health facilities and the role of pharmacists, and this is critical for COVID-19. The week after, we have a team of pharmacists from Scotland, again, who will be talking to us about, let me just check that. It's good that I talk about what's coming. They'll be talking about pharmacoepidemiology and drug utilization in the era of COVID-19. So please stay tuned for our Wednesday morning dialogues. It's always such an insightful and rich experience learning, of continuous learning. Thank you to our distinguished panelists, Dr. Wawera, Dr. Shipa, Dr. Faith. Thank you for bringing your experience from Coast General to enlighten us this morning. And thank you, Peter, for your support in the background, just sharing the slides and coordinating this session. So from PSK, good day to you all. We'll see you next week. Thank you very much.